Well, I think we're just about time to make a start. So first of all, welcome everyone to round two of the focus group discussions on collateral damage caused by healthcare systems in COVID-19 mode. On the screen, obviously, at the moment, you can see the some of the rules that we just have for today's discussion. So, as usual, just microphones off, webcams muted. If you wanted to speak, please switch on your microphone to indicate that you wish to, and then we'll obviously our moderators will try and get round to each person and give a fair opportunity for everyone to speak. Also, at the same time, please feel free to use the chat box to express any opinions or comments or questions, which all of this will be recorded as well, so we'll save the chat box and everything else. In terms of the main questions for today, we're going to divide it into two parts. So first of all, we'll be focusing on mental health. So the main questions of observations, potential causes, vulnerable groups, and strategies to tackle this, as well as the positive effects. And the same again in part two for elderly care. So the same main questions. What I'm going to do briefly now as well is also show you the following slide. My colleague Sarah Berkman and myself will hopefully be turning the results of these focus groups into a small publication. It's in early development at the moment, but what we're going to be doing is having a focus on most of the topics that we'll look at today. So reasons and potential causes, the extent of impacts, any additional affected populations, and existing strategies and processes, as well as the positive effects. So we'll be, alongside the recording, we'll be making notes ourselves. And also, in addition to this, I would like to ask if you do have any time, we're also conducting a brief survey in the organisation of primary care for the coronavirus. So it's split into two parts of processes and guidance, and experience and observations. And the link is there. So if you please feel free to, if you have any time, fill it in. Doesn't even have to be all the way. Whatever you can do will be much appreciated. Also, if you have any issue with us obviously making this recording or making notes, please let me know, or Diedrich or myself, and that'll be no problem. Okay, what I will do then, I will hand over to our moderators, Sarah and Diedrich, and yeah, have a nice session, everyone.
Sorry, I forgot my microphone. Thank you, Tom, for this short introduction. Good to know for everybody that these are our plans, and we think we have a role to play as a European Forum for Primary Care, making clear what is collateral damage for society now with healthcare systems in COVID-19 mode. And if you talk about this collateral damage, it's broad. Just to introduce the theme, it can be from non-referring patients to secondary care, reduced availability of specialists, the absence of therapists and social workers. It's working from distance, the physical distance between professionals and patients. But it also relates to shutdown measures, causing all kinds of problems for people, anxiety, loneliness, and the increased problems for vulnerable groups in particularly who had already a difficult time, but now are affected even more. So that has been discussed already in round one for a large part, but we want, as Tom already explained, we want to focus even more on the mental health issues. And I'm happy that we have a long list of a broad list of professions now in our focus group, with clinical and community psychologists, with a dentist, with a physiotherapist, with medical doctors, with a dietitian. So I think that makes the broad approach of the European Forum for Primary Care even more valuable. And I think if we talk about mental health issues caused by the health systems in COVID-19 mode, all these different professionals have their own experiences. So I'm happy to hear your input, and I want to go to the first issue of what kind of observations you have seen if we talk about mental health issues at primary care level. Please, who is willing to take the floor as a first speaker in this respect? What kind of observations you have seen? Ian.
Yeah, I don't mind. So last week I was a bit more positive that actually all the worries weren't coming in, but I think they certainly are now. So at the start, you know, our Chancellor of the Exchequer was saying, well, there's no problem, we've got an open book and we'll support everybody. Now he's starting to say, well, actually, we can't support everybody and there will be casualties, and a lot of people know the casualties. So a lot of people are phoning in the doctor now, and partly with money worries, partly with health worries. So people with cancer problems and people who are on chemotherapy and things like that. I mean, they're actually on the side getting delayed and potentially not getting the treatments. So because everything is really being focused on the if you like, the front line. So we've got that. We've got the things like the trainee GPs are actually being pulled into the hospitals, and you know, there's certainly huge worry still in the front line because of the overwhelming risk of getting coronavirus, and they are catching it. My daughter's boyfriend, for instance, has already had it, and he was working in A&E and he's got over it. But we have the Chancellor saying, well, there's enough protective gear if the doctors use it wisely now, where there still blatantly isn't actually, and it's not good enough, and so on. So there's a huge amount of stress of very young doctors actually having to break bad news to pay relatives over the phone and that kind of thing. And the other side, which is very worrying, is there's been a 7-fold increase in the number of calls to the helpline for domestic violence, corresponding 25% increase for the people who are the perpetrators. So some of them are sort of realizing they need help too, but not to the same extent. And I think, you know, there's a lot of the worry is when this is going to end, and there's certainly, people who are anxious already. And the other thing that's happening in the mental health system is people aren't coming forward so much, but when they are, there's sort of delays in the system because it can't cope. So, you know, even people with suicidal thoughts are intensifying, or potentially having to wait 2 or 3 weeks before their case gets to an internet committee to decide whether they need support. And the other thing, which I just don't know what's happening, is, you know, what is happening with the suicide rate and things like that. We do know that, so the organisation I've been working with, which was really a drop-in centre, totally voluntary drop-in centre for people with mental health problems, they've had 2 suicides. And we don't know all the backgrounds and the reasons, because it's, you know, it's hard to find out. We can only suspect it's because of loneliness and fear and aggravation of mental health problems already. But definitely people with mental health problems, it is aggravating them. Yeah. So that's probably enough to start things off. But it is a worrying situation.
Thank you, Ian. That helps a lot. One question about these people delaying in presenting themselves. Do you know if these are known patients or new people also delaying their first presence to healthcare professionals in?
That's a good question. I don't think we can tell. I mean, I got this information really from the community mental health team. And so most of them are dealing with people who are already in the system and already getting support from secondary care. So I think there's some that are, you know, dip over lip, and then some of them are coming through to the GPs, and the GPs are actually doing a lot of the talk downs and generally quite successfully without having to. I mean, new prescriptions probably aren't. There does tend to be more talk and rather less prescribing, although there's certain adjustments in doses and things, but there doesn't seem to, and there's, I suppose the GPs are, yeah, they are talking to people, new people who have, if you like, probably have more physical health problems, but because there's this extra worry, there's definitely a the mental health element is coming to the fore.
Yeah, yeah. Ken, you want to say something? Yeah, drop in.
Just to complement things that Ian has said. He hasn't mentioned the social care sector, and particularly residential homes. They're having big problems. Some are publicly owned, but a lot are privately owned, and they're having difficulty in getting PPE. They're big concerns with the carers about this, and of course there are stresses for the staff and also for the elderly who are in these homes and are not seeing their relatives because they are in lockdown, and that's causing a lot of distress there. So I think we mustn't forget about the social care aspect as well.
Yeah, sure. So indeed, social care, maybe some experiences from other countries to be added. For the elderly care, we will continue in the second part to focus more on this. But indeed, increase of domestic violence, social care. What about the Netherlands or Greece? Any contributions to this?
Yeah, after I can refer to what Ian told us, and that's recognizable for the Netherlands. And at the same time, you see that after quite a lot of weeks of hard work by nurses and primary care physicians and teams in the neighborhoods, the tiredness is coming up. And the distress and the choice, what choices do I make between my work and my family, and what has the country done for me? And so these questions rise up after, well, we are now for 4 weeks from the distancing, and personally I find the word social distancing very wrong, because it's not social distancing, it's about physical distance, and I'm surprised that it isn't corrected yet.
Do you mean in our communication or in general WHO communication? Because I believe there in the WHO they have recognized that is the wrong direction, and certainly if we talk about mental health issues, we should much more speak about physical distancing.
Yes, but in the Netherlands, physical distancing is hardly a topic right now.
Yeah. You're right. I agree with you. Any issue? I saw the microphone of Lefteris. Could you say something about?
Yes, thank you. Yes, I want to speak for that. Thank you for this webinar. I see that people are physically inactive these days. They have stress when they are in their houses. They have problems of chronic pain. There is an increase in chronic pain, and they have difficulties of movement. And there are difficulties to visit a place where they can get activities, sports, or such things. It's a difficult time for them. And this issue increases mental health issues to everybody.
Yeah.
There is an increasing stress from the inactivity that people have, especially in the elder, but not only for the elderly, for everybody.
And for example, you as a physiotherapist in Greece, you have still some activity in your practice. Are there, for example,
yes,
exercises or what? How?
No. We have a few only for people that their life is at risk when they have a broke leg or heart surgery. We have only 5% of the people that we normally have. The other people not go outside of their houses for physical therapy. And we have some physical therapists trying to make a telerehabilitation, to speak via via platforms to help their patients.
Yeah. And so I conclude, if there is a real physical need of risks that muscles will be contracted or whatever.
Not for muscle. If you have a nerve damage or we have a brain injury, only for a very difficult situation. For muscle, for pains, people don't go outside their houses for muscular strengths.
Okay, clear.
Yes, and this increase the stress and the problems and the inactivity that they have.
Yeah. Okay, thank you for your contribution.
Thank you.
So I close. Yeah. Let's. These are observations. If you see the potential causes, what can it cause on the long term? Or no, first on the short term and then on the long term for these patients you see as at a potential risk. I would like to have some input from the Lorna French. You are new for me, but you are from a clinical psychologist working from the UK or France. I'm not sure. Please introduce yourself, maybe shortly.
Yes, hi. So I'm Lorna French. I'm a trainee clinical psychologist in the UK, in England. At the moment, we're sort of aiming to put together a specialist service for staff who are on the front line and kind of offering some resilience work or trauma-based work for those staff. So I guess for us, what's been most important is impact on staff of seeing kind of the difficulties that you're talking about, and the impact of managing personal risk, whilst also aiming to provide kind of the best service possible, really.
Yeah, that relates to what Ian was saying, that there is a lot of stress among young doctors and other professionals. Stress from the risk to get contaminated as well, the risk to spread the virus via your activities. I think a lot of home nurses, home care professionals have have an issue with that. They jump from one house to the other, mostly with vulnerable groups. And they feel a lot of stress. Do you particularly have your activities for some of those professionals?
So at the moment, we're in a level of kind of service development and thinking about what types of pathways we would like to include. We are thinking about social care staff, so that's probably likely to involve home care nurses, and I guess that combination of managing personal risk, whilst I guess in the UK, I know there's a lot of kind of hero narrative at the moment with staff, and that resulting in kind of additional pressure on people to feel they must do their jobs at great personal risk. So that any staff that, including home care nurses, including social services, that are kind of feeling those tensions, we can hopefully start to offer a service to.
Yeah, okay, thanks. That's already a little bit like strategies to tackle the mitigation of collateral damage. Let's move a little bit back to potential causes. In a way, the stress around COVID-19 is one of the causes, but I think in particularly for a lot of people at risk for mental health, the restrictions in living a life in social to have your people around you, which you can share your anxiousness and so on, is one of the biggest causes. Can we give some examples, already clear examples of this from different countries? Does somebody have some clear examples from this?
I told you last time that there's a neighbor. She's 19 years old, and her son has a brain tumor. Is in the hospital. She cannot visit him, and the other kids are afraid that their mom is going to be infected, so they want to visit her from fear. And the loneliness and the stress is, well, she's losing weight, and that's just one single example. But there's a lot of damage that is not seen yet right now. That will be seen after a half year if we have passed this crisis. But I think there is a lot of personal damage or loss or grief we cannot see or we cannot mention right now.
Yeah, but many of you see regularly their normal patients. You know your patients, like a physiotherapist, or Ken, maybe you as well as a dentist. You know your patients, and then some of them, although you only treat them for dentistry or physiotherapist, you know that they are at risk for being well, exactly what Dineke said: loneliness, but also anxiousness. Do you have examples or maybe percentage of people you think they are at risk for this kind of collateral damage?
Well, Ken here. Well, I don't think that this is the case at present, because of course most of my colleagues are only seeing people with dental emergencies. They're not seeing patients routinely. But yes, I mean, it depends very much, I think, on where you are practicing and the nature of your practice. But certainly, if you have lots of older patients, or if you're working in socially deprived areas, you can see the people who are at risk for both mental issues and also for abuse. And of course, manifestations of physical abuse you can often see with damage to lips and faces. So you do get a feel for that. You're quite right.
Yeah. May I ask, Shanna Huisman, you are a dietitian. You see your normal patients or clients with feeding issues, but you also see that some of them are vulnerable to any other difficulties in life. Do you have any experiences in that respect, that you see those people also? I just mentioned domestic violence. You see them passing or know that they are at home and they have their problems?
Well, I'm an intern, so I don't see much people, and everything is through the phone. So no, I don't have really an answer, but the older people are get drink nutrition if they need it, and yeah, it's going on. So
okay,
I don't see that much people now.
No. But before the crisis, you had some. You had a group of patients or a group of clients which returned on a regular basis, and now you don't see them anymore.
No.
And are you think there are any at risk for mental health problems?
Yes, especially the elderly, but yes.
Yeah. Any other from the other countries, from the other professions that you think, well, I had my regular patients, and I'm sure those are now really at risk. Just single examples or numbers?
Yeah. Can I speak?
Yes, go ahead, Lefteris.
Yes, the patients that I have that has chronic conditions like low back pain, it's normally combined with mental problems like stress and such things. I think that these people, their problems are getting bigger and bigger with the situation with COVID.
Yeah. Okay.
These people that have low back pain problems.
Low back pain. Yeah.
And it's a cycle now. You have an increase. They don't move. They have more pain. The muscles are getting weaker. This is make a cycle that make the problem bigger and bigger every day.
Yeah. Okay. I saw the microphone of Josephine van Olmen from Belgium. Doctor, can you say a word about this, the mental health issues, and what are the vulnerable groups in particularly in this respect?
Yeah, I'm a professor at University of Antwerp General Practice, but I work in both the Netherlands and Belgium, so I speak of both. I think what I see mental problems is I see a lot of elderly people coming into problems, and I do quite a lot of shifts after hours care. And while the routine care for Alzheimer patients is slowed down, you see more problems in the night with exploding cases and people needing emergency admissions because of informal care not being able to cope any longer. Substantially more in quantity than what I'd seen before. That's mental health wise, so especially in the elderly people. But not only in elderly people, also people with chronic mental conditions, I'd say. It's a combination of fear, not getting their routine support, and the quarantine measures, which really accelerates the stress and comes out especially in the after hour moment.
Yeah.
And on terms, I don't, because I came in just now from another meeting, so I missed, but in other terms of collateral damage, I have noticed at least 3 to 5 cases of serious non-COVID related pathology for which I had a lot of trouble of getting people referred to the hospital to be examined by a surgeon or a cardiologist. So that was also collateral damage, an ileus or cholecystitis, which I had to treat at home with antibiotics without having been seen by a surgeon, those kind of things.
Yeah.
So I don't know if you already discussed that, but.
Well, we discussed that last week, and we focus now on the mental health issues because it was seen as one of the most important missed treatments and care at this period, at this difficult period. Can I ask you directly the question on do you have already strategies to tackle mitigation ways of mitigation to come along on these problems of mental health issues?
No. Well, no, I am my practice in the Netherlands is in Zeeuws-Vlaanderen, in the border area with Belgium. And yes, last week, but I have to look it up. Last week, our main provider of second line psychiatric care opened a special number for patients to call. So yes, I think we do have a mitigation strategy which started 1 week ago. Okay. For elderly people, nothing has been in place yet. And I just came out of a meeting with Belgium colleagues from the other universities where we did not discuss mental health, but I've not seen that. A lot of focus has been on providing care for healthcare workers with with stress symptoms, etc., but less so for the chronic mental health patients.
Yeah, but that was also mentioned before you entered the meeting by our colleague also from UK. She has left already, I think, that there was indeed a project started on increasing the resilience of the workforce for all the stress factors they face. So that's another one example then that you present from your Belgium experience. Yeah. Okay. Yeah. Any other contributions on how to mitigate, how to tackle these mental health problems of many of your patients and clients or of the health workforce? Ian, do you have any examples at the moment?
Yeah, I mean, I am part of a webinar, well, I teach webinars anyway, but a webinar organization called Webinars for GPs, and we've already got a support group going up every Wednesday, and I'm going to give a webinar talk on, because one of my worries is GPs always have problems to explain to patients how they cope with difficult teenagers and children, and obviously children and teenagers can be very emotional at the moment. So I'm putting together a webinar to actually help them explain to patients really that you know, it's an emotional time, but you've got to accept the emotions and actually slow down and work it through logically, and how you do that. The other thing is that, you know, there is so also the guy in charge of this organisation is doing a good job, because he recognised that a lot of the young hospital doctors, because they move around so much, actually don't register with a GP, and so don't have anyone to talk to. So it's about just getting sort of help and support groups and that kind of thing. And I put in the text, I noticed we're not really using the text this week, but you know, it's always the problem with mental health is well, everything's coming second to coronavirus now, so I can't complain on that score. But you know, if we came up with a proposal, we said, well, you know, maybe every GP should be checking out the people with mental health problems and seeing that they're getting the right support and help. You know, it may be something that we could put forward as a proposal or a statement. The trouble is, often as as GP, you get fed up with these things, because then social services aren't working, or all that happens is they hit the next queue. But I think we should recognise that primary care doctors are very good at talking to people and talking people down, so that though this would take time, it's probably a very positive thing to do. Yeah.
Okay, thanks. You remind us to use the chat box, which is in where you can put some written contributions on experiences you had. Just a few minutes on positive effects. Are there any, if we look at mental health and primary care, are there any positive effects of the corona crisis and how the health systems has now has been put into this corona crisis? Do we see any positive effects?
What we see is in the Netherlands, there is more attention to informal care and the meaning of informal care. There is more attention of loneliness, because before Corona crisis, there was also a lot of people who were very lonely and without any care. So and they kept help from strangers, from students, and so I think these are positive things. And what I also find it very positive is the connection between the university knowledge and the daily practice and practical problems we struggle with right now, and the universities are and the professors are contribute much more to actual problems, and I think that's a very nice thing, and also that the distance between practice and university and scientific knowledge is less.
Yeah. Any other positive experiences in the last couple of weeks? Unexpected, maybe? No, for the moment not. Then I would like to move on to the care for elderly. And of course, it's related, mental health care for elderly. But one of the big differences, I think, is that care for elderly is for a large part provided at home. I mean, a lot of people couldn't move already and cannot move anymore because of physical distances and risk they have if they go out. So is there any, for example, I asked Lefteris as a physiotherapist, are you able to provide care at home for some of the elderly which are really in a big need?
Yes, we have the ability to visit their home. It's a normal activity to visit them at their home.
Okay, so that's still allowed. And
yes, and we help. We can help them, but there are difficulties. It's difficult to find a PPE mask. It's difficult to go and to buy such things. There is a great difficulty, not so much when you work in a hospital. But when you work in the private sector, it's difficult to find masks and other things that you have to wear, because everyone has to think that it may carry COVID.
Yeah.
You understand that, and it's a problem. I don't know if you have a problem to find masks in your country, but in Greece it's difficult. Only if you work in the hospital.
Well, it's a huge problem. They try to solve in the Netherlands, but maybe some of the other participants can say a few words on that, Pim or Dineke, because for workers, for health professionals that provide home care, it's really a difficult time, and we see a lot of contaminations through the work of home care workers. Any additional thoughts about that? Dineke, you had some contribution. Oh, Pim is.
Well, I can mention indeed that for home care, there is very little PPE available, and there are maybe guidelines, but many home care organizations, of which we have a large number in the Netherlands, do not actively help their home care visitors to use this material. So there is a risk for the home care staff indeed, and in addition to that, elderly people are very vulnerable to COVID. So there is an enormous fear to not only be contaminated, but also to contaminate clients or people at home. So that does reduce home care for quite some elderly people, and they receive the bare minimum. And there are examples, I know concrete examples of people who haven't been receiving their regular home care, and they just get some food, and so mentally and physically, and their whole household is then getting into distress indeed. So I think that here is a problem that is not sufficiently addressed yet in the Netherlands.
Josephine from Belgium, do you recognize this problem in the Belgian regions for home care workers?
Yes, they are, and I think we have similar discussions in Belgium as in the Netherlands about the unbalanced attention for hospitals in the first place, and now seeing the big mountain of infections and how to work with people both in home care as in elderly care homes. In Belgium, they have now taken, for elderly care homes, they have started massively testing everybody, sick and non-sick, in order to be able to make separate departments within home care homes. But for the home care organizations, and that's still much more, I'd say, versnipperd, so fragmented in Belgium than it is in the Netherlands. And indeed, with a lot of nurses working on a private basis, so the protection and knowledge there is even worse. And the phone care, I agree with what somebody said, that the collaboration between universities and healthcare providers in the field has intensified, also in Belgium. And in Leuven, for instance, I just spoke to one of the staff members who said, I'm now fully involved in the day-to-day management of an elderly care home, because basically the staff which was there had no clue. So people have really gone a bit out of their towers into working in the field because the need is so high.
To name already a positive effect in that respect, yeah.
Yeah, that's a positive effect, but really a response to a very pressing need, which can no longer be ignored.
Yeah. But if you look at these home care professionals unprotected, do you agree with Pim that this results in reducing the amount of care provided, or do you see that home care professionals are just continuing without any protection, being in distress and causing even further contamination? What direction it goes?
I have not enough data about that, and that's one of the, so we cannot say these are only incidental stories. But one of the big problems is that we don't collect enough data of what's going on outside of the hospitals.
Yeah, okay, but to respond on that, Tom, my colleague, and Sarah, who are listening well and making notes and recording it all, they are going towards a publication on all the collateral damage issues, recognized and counted. So we try to get something on paper, a publication on this issue. So I hope that helps. Tuba from Turkey, she joined halfway. Can you say something about the elderly care in, I think it's Izmir, where you are working at hospital and primary care level, and what are your observations, and what are the difficulties for healthcare professionals at this moment?
Yes, hi everyone. I am working in Antalya. In Turkey, home care services belongs to hospitals in secondary care, but family physicians, psychologists, and dietetics and nurses are working on the team. For example, in my hospital, I have 4 teams for home care service, and we have almost 1,050 patients. But with the COVID event, we have more patients than before, and we had a bad experience about it. Our first patient was a man 65 years old, and his grandson came from Italy. And our home care workers didn't have any protective equipment, personal equipment, because we thought that we won't be faced with this illness quickly. But then we suddenly saw it, and now we gave them personal equipment, glasses, masks, and the other things. And you know, in Turkey, it is obligatory. They couldn't go outside. So we had to go and take care of them.
And what is then the effect on these healthcare professionals being confronted with positive COVID-19 patients being there unprotected? Are they now scared? Are they now not going, or they are forced to go but still scared? How does it work?
At the first time, they scared, but then they take some education about this topic, and we gave all the equipment they need. And now they are good and silent. They don't afraid of it. And I don't know, maybe because of the weather, in Antalya we have less cases, and and because of this, workers feel safe, more safer than other parts of the Turkey, like Istanbul or Izmir.
Yeah. Okay. Thanks. Going back.
Sorry.
Yes, go ahead.
I have also one question. How do you deal with chronically ill patients and multimorbidity in patients who are also COVID positive and are not possible to meet doctors and do their controls, and probably are not eating normally for diabetes? Is there something mentioned probably from dietitians, or yeah?
Anybody elderly with chronic conditions, multimorbidity, how they are treated now at the moment? Is there any specific, Josephine?
Well, I think we try to do a lot with the phone self-management support, because that's what it is. In fact, if you had a chronic care system in place before COVID, then part of the care was self-management support, which was in our health system decentralized as much as possible to nurses and to informal caregivers. So we tried to continue that on a phone basis and with adjusted information on websites. And to minimize as possible the face-to-face contacts. But if you have the feeling that in the routine care you see that people are deteriorating, then you switch from the maintenance support to really dealing again with an exacerbation or deterioration. So that means that you run from chronic to an acute management, in fact.
Yeah. Clear. Any other experiences with chronic conditions? Maybe Lefteris also, your chronic patients, do they get the treatment they need from out of your team as a physiotherapist, but also working together with the GP and so on?
There are many difficulties from people with orthopedic conditions that needed to make a second surgery, because we have the oral surgeries are postponed now due to COVID, and there are people that would normally would be able to move again after 2 or 3 months. Now they are in the 5th or the 6th month that they cannot make their surgeries and to make their lives better. We have problems now. But I think that they understand that is a condition that we have to take precautions to stop the spread of COVID-19. There are many difficulties and other issues that like diabetes or heart problems, heart disease. Everything is postponed now because everybody is afraid to visit a hospital or to visit their GP or their pathologist to get advice.
Yeah. Okay. May I ask you all a rather difficult question, which I have my own parents as well in high ages, so 85 plus, and my father in living still at home, and the other, my father and mother-in-law, living in a nursing home. The clear issue is that they are losing healthy life years. But I'm struggling with that should be huge, but how to quantify? How can we make sure that all those stories of people suffering from these difficult times are getting counted into a figure that presents the loss of healthy life years? Any ideas? How should we make that clear to policymakers, to politicians?
Unmuted.
Oh, perhaps we can make a very short questionnaire, and I've got a lot of friends and friends from France working in the elderly care, and perhaps in that way we can give some information, but also through online, and not all elderly are online, but relatives are online. And that's, I think, the most easy way to get some data.
Thanks, Tineke. Any other suggestions? How can we make clear? How can we make the stories clear from elderly who are moving into loneliness, anxiousness because of the whole situation of isolation and so on?
I mean, can I say something? So, I mean, my parents are 1995, and as you know, they've self-isolated, obviously. But the situation, I mean, they actually aren't allowed to go out for exercise, so they take it's not really a risk to go down the cul-de-sac and they've actually got to know all their neighbours, and they've been absolutely very pleased that neighbours have. You knocked on the door at a distance and says, "Is there anything you want? Can we help?" That kind of thing. My mother is quite a stalwart in the church, and she's almost taken over the act of ringing everybody round in the congregation and checking they're all right. The surprising thing is that when she rings a lot of people, they then say, "Well, thanks, no one else has contacted me." And she says, "Well, you've got a phone, why don't you ring them?" And so I think some encouragement on just simple things like that could boost morale and actually just make it normal that why aren't we encouraging our elderly to I agree a lot of them struggle with technology, and my parents are the same, but the phone, they can is still there, and they can talk to people, and it is actually one of the things that keeps being told about coronavirus in England is that we're not getting to know our communities, even though we have to keep a distance for them. But there is this bit of goodwill between us, and building on that, I think, is a very positive thing.
Yeah, so I just wanted to mention this is again already one of the positive aspects, and at the same time one of the mitigation strategies, using at least the phone, which is used, of course, a lot nowadays, and including all the online technology. But I assume still there are plenty of people who are lacking this. People without much family or whatever, they are really back to themselves, completely lost, not having contact with other people.
Well, maybe we should do. Sorry to say one more thing. So maybe we should be having a sort of, how we have a sort of, you should eat 5 vegetables and fruit a day. We should be saying to people, we should be making 2 phone calls a day, or this is all, or even 5 phone calls. But I think it is about teaching people to be proactive, that they need this. So social isolation is not good for you, and actually we should be seeking out people who are lonely and giving them support, as so many people want to.
Yeah. Any other suggestions for mitigation? I saw the visiting boxes. Does it sound familiar already for you, or should I explain? Visiting boxes with glass in nursing homes. Have you seen them in your country already?
No, I haven't seen.
What are they?
So Ken, it's like that they just put a glass box, of course, where people can stand in, with a corridor to this glass box, and then it's in the middle of the nursing home, and so people separated with a glass wall can still meet each other in the nursing home. So relatives can go into the box and having contact with their father or mother at older age, and that's, I think, a very nice and valuable new. Not really technology. It's just an initiative which should be followed by any nursing home, I think.
Well, that sounds a great idea. I think it needs publicizing, doesn't it, so that more people are aware of it.
Yeah. Have you heard about it, Ian, in the UK, or Lefteris in Greece? First, Ian.
No, I've got exactly the same thought. It's a good idea. How easy they are to put in, I don't know, but certainly a good way of encouraging.
Yeah.
Yeah.
Lefteris, heard about it in Greece?
No, I haven't heard it. But it seems a good idea.
In Belgium, have you seen this initiative, Josephine?
No, we haven't.
Okay.
I haven't.
You haven't. Yeah. Okay. Well, that's just one of the ideas. Any other positive effects to end up this session? If we look at elderly care for the elderly at community level in the COVID-19 mode, did you see any other positive effects?
Yeah, I think the widening of informal support, more volunteers helping out for services for elderly people.
Yeah, that's definitely seen in the Dutch society as well. It was said yesterday on the 8 o'clock news that it shouldn't be a one-trick pony. So there should be some continuity in all these initiatives. But I think I'm positive always, and I think that could be maintained also after COVID-19 crisis. Other positive experiences?
I think people are generally more caring now. They have time to think about other people because of social isolation. Actually, I think it should be called anti-social isolation, because you don't socialize, but that's by the way.
Okay, yeah. Any other remark or whatever? If not, may I just invite you, because this is partly a new group. If you think there is a specific theme, topic which we should focus more, in the previous focus groups, it was mentioned, for example, pregnant women, but there could be also something about migrants in particularly, or you have other suggestions. Could you put that in the chat box for the last minutes we are meeting here? And then based on these suggestions, we can go forward and maybe plan in 1 or 2 weeks again a focus group on specific that topic or theme. That would be very helpful. Any other urgent remark from one of you? If so, please open your microphone and then I give you the floor. No.
I'd just like to thank you and Tom and your team for setting this up. It's always very interesting, and it helps tremendously to have an insight into what's going on in the other countries. So thank you very much for organizing this.
Thanks a lot, Ken. My pleasure is yours. Sarah, you want to say something?
May I only have one question? Do you see a change in social interaction between different professionals, also working for or working with elderly or mental health people in teams? Are there nearly more flat hierarchies, or did there something change? Did you mention something, or is it the same as before?
So I think you specifically ask for what are there changes in the hierarchical structure of your professionals at primary care level. So that's the last question, and then I set you free. Any observations on this, Josephine?
Not yet, but this crisis is certainly the start of a more intense debate about reorganization of primary care in Belgium. So it's a start of it, but not yet an immediate effect on hierarchical relations, I'd say. What you do see is, and that links to what we said, the solidarity between healthcare professionals and maybe academic centers and the fields. So there's an outcry from the relatively lower educated staff in nursing homes for more expertise, and that is being filled up by higher echelon cadres. So in that way, yes, formation of, or I'd say an influx of expertise to help lower levels, but not yet a real change in hierarchy. I think that takes more time though.
Any other observations in this respect?
In Turkey, we suddenly learned that we need a social team about home care services, because we only make these services with family physicians and nurses and dietetics. But these people need extra things and supports. So now we have volunteer social teams that are made by government and also with government teams and volunteer social teams. But it is shown that there is a need about it, and I think they will organize it later.
Yeah, okay, thanks. I really want to close because otherwise we run out of time. Tom, maybe you can show the other slide with the survey, because I really want to make you aware of our survey, which is conducted on the organization of primary care in COVID-19 mode. And there are also some questions on collateral damage. And we definitely would like to have your contributions in this survey as well. That will be also used for the publication Sarah and Tom are supposed to write. We also want to make a statement as a European Forum for Primary Care, and that we will try to make as soon as possible to make politicians, policymakers aware of the need to tackle also the collateral damage caused by healthcare systems in COVID-19 mode. Wishing you all a good day. If you're not yet a member, please consider, because we are really looking for this input, not only on these webinars and focus groups, but also in other ways. And it would be helpful to have more members joining us. Thanks a lot, and looking forward to any future meeting on site or in COVID-19 mode online. Bye-bye.